Good morning. My name is Dr. Shahriyar. I'm an infectious disease fellow from Wayne State University, and today I'll be presenting a quality improvement project that is stated as in the first line, comparison of initial treatment strategies for outpatients with suspected community acquired. And over here we have our authors and their affiliation. So in introduction, initial therapies for outpatient community-acquired pneumonia remains variable based on geographic locations and resistant patterns. IDSA guidelines recommend either monotherapy for patients who lack comorbids or risk factors for resistant organisms, or combination therapy for those at risk for severe pneumonia. Despite clinical guidances, it remains a challenge for providers to prescribe guideline-recommended therapies. And so assessments of local practices and outcomes are essential for optimal community-acquired pneumonia management. So in methods, this quality improvement project, it was a retrospective review of outpatient antibiotics that was prescribed from January 2023 to March 2024 for the indication of pneumonia. It was conducted at a VA hospital. Clinical and antibiotic data was collected and analyzed for comorbidities, risk factors, and outcomes, and assessed for indications for monotherapy and combination therapy, as per current IDSA guidelines. So antibiotics assessed included amoxicillin, doxycycline, azithromycin, amoxicillin slash clavulanic acid, either as a monotherapy or combination therapy with azithromycin or doxycycline. And outcomes were compared between these two groups. So over here, this table, it shows on the left-hand corner the antibiotics and the combination of antibiotics. And on the right-hand corner are the different variables, including median age, mean duration of treatment, ordering locations, like whether the antibiotic was ordered by the ED physician, primary care, or other setup, gender, and the race as well, African American, Caucasians, and Hispanics, presence of comorbidities, presence of multiple comorbidities, antibiotics prescribed in the past 90 days, presence of fever, elevated white cell count, and presence of infiltrates on chest X-ray. And over here, you can have a look at the, the data as well. So the results, as you can see over here, that the only thing that was statistically significant was the presence of fever and the monotherapy. So that meant that it was the presence of fever and monotherapy was prescribed more as compared to dual antibiotic therapy. Other than that, the other variables were not significant, even if we can see that presence of multiple comorbidities have no association with monotherapy or combination therapy. So in conclusion and discussion, combination therapy for community-acquired pneumonia was prescribed in only 56% of guideline-eligible patients. There was no statistical significant p-value of 0.10 between prescribing monotherapy and combination therapy with respect to hormone, indicating that antibiotic prescription for CAP was variable and showed low concordance with guideline recommendations. So, audits and provider feedback on antibiotic prescription patterns are necessary to guide appropriate therapy in the treatment of CAP. So, in conclusion, We plan on expanding our study and reevaluating the diagnosis of pneumonia that's based on the guideline from IBS. We also plan on identifying data for potential confounders such as COVID-19 and other respiratory illnesses such as asthma. So based on these findings, we'll provide appropriate feedback to ED physicians and PCP and also support stewardship initiatives. So generally it means that we'll reorganize the data. Right, the diagnosis of pneumonia was based on individual primary care provider or ED physician. And over here, we'll re-stratify the data and the diagnosis over here will be based on the guidelines from IBS. And from there on, we'll move forward and reevaluate the data. Thank you.